Okay. Thank you for Chairman. My name is Haruya Yamane from Japan. 1 week ago, my son had a high fever and he was infected COVID-19. And 3 days ago, I was also diagnosed with COVID-19 infection. So my presentation may include cough or any noise. Please forgive me. But fortunately, I'm doing well, and I'm very glad to join this conference. Thanks for program members and online technology. Today, I will make a presentation about indication of non-surgical management for acute limb ischemia and introduce our novel technique. Just a moment, there's no COI. Acute limb ischemia, ALI, is a sudden decrease of limb perfusion that has a potential threat of life and limb viability. Thrombectomy using a Fogarty catheter is recognized as first-line treatment, but endovascular treatment, EVT, has recently developed as alternative to surgical revascularization for ALI. There are several conventional EVT procedures for ALI. However, their indication remains unclear. Before main topics start, etiology and severity of ALI are needed to understand. The etiology of ALI can be classified into several categories, but almost ALI was occurred 2 reasons. They are native vessel thrombolysis and embolization. Native vessel thrombolysis usually occur in the atherosclerotic plaque. Those patients often have risk factors such as hypertension, diabetes, dyslipidemia, or smoking. Embolism is often derived from intracardiac thrombus due to atrial fibrillation. And recently, debris from aortic ruptured plaque is also recognized as important cause of embolization. More than 70% ALI occur due to these 2 etiologies. Next, we explain about severity of ALI. Severity of ALI can be classified into 4 stages depending on the limb viability. Stage 1 means viable limb. In many cases, Doppler signal is audible and emergent revascularization is not required. Stage 2 means threatened limb viability. Emergent revascularization as soon as possible is needed for limb salvage. Stage 2 is divided into 2 categories. Stage 2B shows more severe condition. Sensory loss or muscle weakness are important signs of stage 2B. Stage 3 means irreversible limb damage. In this stage, complete limb salvage will not be achieved. In short, only stage 2 needs emergent revascularization for limb salvage. For revascularization of ALI, surgical procedure has been performed traditionally. Even now, it is recognized as a first-line treatment. Thrombectomy using a Fogarty catheter like that was a game changer for ALI treatment. Especially, it is extremely effective for the patient with ALI due to embolization. These patients do not have atherosclerotic change lesions So Fogarty catheter can pass the lesion easily and remove embolic material like this image. As you can see, large thrombus could be removed. However, it can cause some complications such as vessel dissection and distal embolization of below the knee artery. In addition, it cannot be performed by only cardiologists. It generally needs surgeons' help. So we start to explain conventional non-surgical treatment for LI. First, percutaneous aspiration thrombectomy, PAT. PAT is a simple suction of embolized material by 6 to 8 French catheter. Of course, the catheter can aspirate the material smaller than its size, so the recanalization by PT alone is not frequently successful. PAT is recommended for small vessels, such as below the knee arteries, like this image. Thrombus in BTK artery is often small, so PAT can be effective. Next, catheter-directed thrombolysis, CDT. CDT is also considered as a first-line treatment for LI, according to the current guideline. As the figure shows, CDT uses a March hole catheter. It is inserted into thrombus directly, and thrombolytic drugs is infused through the catheter. CDT can lead to similar clinical outcome compared to surgical treatment, and several clinical trials demonstrated them. However, CDT has an important disadvantage. CDT needs a long time to revascularize. Therefore, for the patient who need emergent revascularization, it should be avoided as initial therapy. CDT should be used in stage 1 patient. Angioplasty and stent implantation is a well-established strategy in chronic artery disease. For LI, the effectiveness of angioplasty is limited, but it is mandatory procedure for underlying atherosclerotic lesion. Stent implantation is widely applicable and useful for LI patient in any stage and any etiologies. However, we should be careful not to deploy it in the non-stenting zone, such as common femoral artery or popliteal artery, because non-stenting zone is located in the medial joint. It easily leads to stent fracture by the joint movement. By the way, in Japan, many disasters frequently occur due to earthquake and or typhoon. Of course, landslides also frequently occurs, as you can see in this picture. In such a case, sometimes we make another route to pass it, such as bypass or tunnel. After making another route, landslide is removed. Finally, another route is also removed. We apply this method to our novel technique for LI. This technique is based on the distal perfusion concept and uses a guide extension catheter named Temporary Endoluminal Bypass technique, TEB technique. The steps on this technique are very simple. First, we evaluate the lesion length. The second, We deliver a guide extension catheter through the occluded lesion. Third, we confirm the contrast flow to the distal arteries. And finally, we administer a thrombolytic drug. Guide extension catheter is used as tunnel. Now I will show a representative case. The patient is an 83-year-old female and she complained of pain and coldness in her left leg. She had some risk factors and she did not have a notable past history. She had some risk factors such as hypertension and past smoking. And she has nothing in particular past history except for the hypertension and past smoking. ABI in her left leg was unmeasurable, and ultrasonography showed occlusion in her left popliteal artery. The Doppler was inaudible in her left leg, and her sensory function are slightly injured. We diagnosed her with grade 2B ALI, and the angiography was performed. We can see the mild atherosclerotic change in the open vessel. It demonstrates the occlusion from distal SFA to popliteal artery, like this image. Besides, below the knee artery couldn't be visualized at all. The wire could pass the lesion easily. After that, we evaluated the lesion by intravascular ultrasonography. This figure shows the schema of IVAS findings. IVAS means intravascular ultrasonography. The red line shows the healthy vessel, and the black line shows the occluded lesion. First, we performed aspiration and balloon dilation, but they couldn't revascularize. We thought that thrombectomy is not applicable because because the lesion advanced to the BTK lesion, and the surgeon in our hospital is under surgery. Stent implantation wouldn't be applicable because popliteal artery is in the non-stenting zone. So we decided to perform TEB technique. IVAS showed that lesion length was over 30 centimeters. So we selected the Guidozilla 2, which is a guide extension catheter with 40 centimeter lumen length. We delivered the guide extension catheter to cover the lesion fully like that. These are the angiogram after TB technique. A lot of thrombus was observed in the popliteal artery. However, we could see the contrast flow to the distal arteries through a guide extension catheter. This movie, the second movie, shows the important feature of this technique. The contrast reaches below the knee artery at first, and after that, popliteal artery is visualized. It makes possible to prevent a limb ischemia and buy time to reduce the thrombus. After that, we started administered Brokinase, which is a thrombolytic drug from the CIS directory. This is a clinical course of angiography. The angiogram showed a reduction of the thrombus gradually. On period 2, the guide extension catheter was removed. A little thrombus can be observed, but the result was acceptable. The blood flow of the BTK arteries were also improved gradually. On period 2, the angiogram showed an acceptable patency, especially ATA gain a good flow. This figure shows timeline of medication. We administered Rokinase at the dose of 240,000 units and heparin at the dose of 10,000 units on POD 0. We stopped Rokinase on POD 1. On the other hand, we continued the anticoagulant therapy with heparin until drug administration was started. Finally, she was discharged without any complications or interventions. TB technique is based on the concept of a distal perfusion. While maintaining the blood flow to the distal part, thrombolysis therapy is conducted. This technique has an advantage of revascularization without deploying any device in the lesion. There are 3 chips in this technique. First, the lesion length should be measured. The guided extension catheter, which has enough length to cover the lesion, should be selected. Guideline PV has 25 centimeter lumen length. Guidogera 2 PV has 40 centimeter lumen length. We can choose 2 types of them, depending on the lesion length in Japan. Second, the proximal edge of the guided extension catheter must be separated from the distal chip of the cyst. Generally, the space shouldn't be made when the intervention is performed. But in this technique, the space is needed to deliver to the blood flow to the distal arteries. Third, the blood flow of the distal artery to the distal arteries should be confirmed. When it is not obtained, we should change the position of the catheter to more distal or change to another tibial artery. This is a summarized table about non-surgical management according to the occluded lesion and LI stage. PAT is effective for the small vessels, such as BTK arteries. CDT is recommended for the patient with stage 1 ALI. Angioplasty is available for any lesion, stage, and etiology. But we need to understand the effectiveness is limited. Stent implantation is often effective and it has high success rate, but we shouldn't not deploy them in the non-stenting zone such as CFA or popliteal artery. Our novel procedure, TB technique, is available for any lesion and any etiology. Of course, TB technique is not first-line therapy. First, we should try conventional treatment. But if they do not work, TB technique can be an option for non-surgical treatment for ALI. This is the conclusion. Thank you for your attention.